completed his fellowship at Stanford and was on faculty at UT Southwestern before joining us here at Swedish. Dr. Khemani and his partner, Dr. Besharat, have really been, I think, quite a force here in our movement disorders program. With just 2 providers, they've recently had certification and national certification as by the National Parkinson's Foundation as a Center of Excellence, as well as national certification as an Ataxia Center of Excellence. To do that and see as many patients as I know that they're both seeing, as well as fundraising, doing research, is really impressive. And he's just a fabulous colleague, and it's my pleasure to welcome him this morning. Thank you.
Thank you, Dr. Elliott. Thank you to the Seattle Science Foundation for inviting me to present Grand Rounds, and thank you all for coming. I know that you can access this conference remotely, but there's something to be said about attending in person and collaborating, talking, joshing, and having breakfast right outside the hall here. And so this conference, the Neurology Grand Rounds, is held every second Thursday, 7:30 to 8:30 a.m. And please welcome in person 6th floor James Tower. With that, I'll get started. What you see on this slide currently is the north rim of the Grand Canyon, and I had the privilege of visiting it last year. I've visited the Grand Canyon on several occasions, but the fall is a particularly spectacular time to visit due to the way the sun hits the rocks, and I thought this was a really cool picture since we are in fall. And with that, let's get started. I'm going to talk about multidisciplinary treatment for ataxias. I was just telling Dr. Elliott that this is a very vast topic, and I've done the mistake of including a lot of information because the ataxias are a very expansive group of degenerative disorders. But for the purpose of this talk, these are my disclosures. My objectives are to speak about multidisciplinary treatment vis-a-vis the 2 cases that I'll be presenting today. I've got several cases, but I think we have time only for a couple, and then we'll have some time for questions. We'll talk briefly about the clinical classification of ataxias, diagnostic approach, and a couple cases. So we cannot talk about the cerebellar ataxias without talking about the cerebellum, but I cannot do a deep dive into the cerebellum and its cytoarchitecture because that might put you all to sleep, number 1, and number 2, that's a lot of information for one morning. But suffice it to say that I call the cerebellum the great integrator. Its fundamental function is to integrate and then process and modulate motor and non-motor function by way of the input that goes into it through its pathways. It ultimately modulates activity of the brain stem, the basal ganglia, and the cerebral cortex. And by doing that, it facilitates precise movements of various body parts and body functions. The eyes, speech and the swallowing apparatus, head and trunk, and limbs. And important to recognize now is the role of the cerebellum in affective, emotional, and cognitive processing. And we'll talk a little bit about that. Initially, it was thought that the cerebellum is primarily a motor output machine, but it integrates thought and emotion as well by way of its connections with various other areas of the brain that are responsible for generation of those emotions and thoughts and behavior. Lesions in the cerebellum or its pathways cause imprecise execution of movements, which we call ataxia, and that's Greek/Latin for disordered. I put thought in parentheses because we will talk about a syndrome which describes dysmetria of thought, a particular problem in executive functioning, visuospatial integration, set shifting, etc., not unlike imprecision of motor movement. And that is the cognitive and emotional function of the cerebellum. This is a cartoon at a very basic level of what a coronal section of the cerebellum looks like. This is a throwback to our medical student and residency days when we were told that the medial part of the cerebellum, a medial part of the cerebellum, and my arrows point to this area, the vermis and the most medial proximal nucleus, the fastigial nucleus, mediates movements of the trunk, mediates gait, eye movements, and speech. And the lateral aspects, which are the hemispheres and the embelliform and dentate nuclei, which is a collection of neurons, modulate appendicular leg movements. There is more to the cerebellum than this. This just really doesn't do it justice because it is only 10% of brain volume, but has 80% of the brain surface area. And that's a lot, and about 50% of the nerve cells of the brain reside in the cerebellum. So that's really a marvel of anatomic packaging, if you will, that tells you how complex this particular structure is. But we don't look at these cartoons in the clinic. What we look at is the MRI, which is the most commonly obtained neuroimaging in the clinic. And here are some scans. This is A is sagittal, B is axial, C is coronal. And what we see most commonly is the vermian area, which is the mid-sagittal section when we're looking for atrophy, because it's particularly prone to lesions and atrophic processes. In the coronal section over here, we look for the middle cerebellar peduncle. For some reason, this area, which connects the pons to the cerebellum, is particularly prone to disease processes, multiple sclerosis, various neurodegenerative areas, etc. So it's good to know where it's located. And then that arrowhead points to the dentate nucleus, also very commonly affected in cerebellar diseases. It's responsible for appendicular movements. And then the lateral hemisphere is very obvious, the largest portion of the cerebellum over here, again, responsible for portions for movement precision and for thought. In the last section over here, I'm going to point to two obscure areas which we don't pay attention to, but are the oldest parts of the cerebellum, the floccular node and the nodular node, the floccular nodular apparatus of the cerebellum. And that is responsible, again, for midline movement, precision of midline movement, including eye movements. This cartoon just describes at a very basic level the somatotopic organization of the cerebellum, is which parts of the cerebellum modulate which parts of the body. I think I've already alluded to that. But one important thing that we have recognized, and I want to tell you that in real life on MRIs, the cerebellum doesn't look like that. The anterior and the posterior lobe are not in one plane. This is a flattened sort of a butterfly impression of the cerebellum, and the anterior lobe is obviously anterior. That is connected to parts of the brain that modulate motor function. We've recognized that now by way of the cerebellum's connections with different parts of the brain. And then the posterior lobe is responsible for modulating neuropsychiatric function by way of its connections with other parts of the brain. And these little cartoons of people hanging out here tell you that the leg area, this is called a homunculus, is subserved by the anterior lobe, and the arms by the superior posterior lobe. And then you have a fractured somatotopy of the cerebellum. You see one homunculus here, one here, and the other here, meaning there are various parts of the cerebellum that govern limb movements by way of their connections with each other. It's not a clean homunculus as you see in the brain. And that's what makes the study of the cerebellum complex. That's what makes it very difficult to see a lesion on the MRI and say, okay, this is going to cause arm problems. It's not as clear cut as that. You have to really look at it at the microscopic level. All right, so what are the symptoms of ataxia? This is, again, very bread and butter medical student resident level information that we get. But because this is a mixed audience, I thought I'd include some of these very fundamentals information. When people come into the clinic, how do you elicit a history from them about cerebellar disorder? They will endorse these symptoms, or you have to get it out of them. Are you walking like a drunk? Are you walking a straight line? Falling, of course, is a very common symptom of cerebellar dysfunction. Is your handwriting deteriorating? Is it scrawly? Are you getting clumsier? Are you knocking over things when you're reaching for objects? Is your speech slurred? Do you have blurred vision? Do you have jumpy vision? And that's a clinical sign. Jumpy vision is when you're looking at the environment, the TV, or someone talking, and their image is shaking. That is called oscillopsia. That is a peculiar cerebellar sign. And dizziness and vertigo are fairly ubiquitous in the world. They're not specific to the cerebellum, but oftentimes people will tell you that this is how my symptoms started with vertigo. Swallowing difficulty comes later on in advanced cerebellar diseases. In terms of doing a clinical exam, the signs we look for in the clinic are very peculiar to the cerebellum. And I'm sorry, I don't have videos for this talk, but I have videos for all of these signs. You see gay sporadic nystagmus, in which the nystagmus is sustained. It's usually bidirectional in both eyes if there is a global cerebellar process. Saccadic dysmetria is overshoot of the eyes, either hypometria or hypermetria. And impaired VOR cancellation, a little difficult to demonstrate, you have to see a video, is when you actually move the head in line with the eyes, there is a catch-up saccade. The eyes stay in place, the head's already moved to the other direction, and then there is a lag between the movement of the eye and the movement of the head. Not specific to the cerebellum, but a good clue that the cerebellum is involved. Macrosaccadic oscillations are just a fancy term for nystagmus of a wide amplitude, but we use the term macrosaccadic oscillations. Cerebellar dysarthria also has a specific quality. It's very different from the speech impediment we see in other conditions, such as Parkinson's disease, which is more hypophonia. One clue that the cerebellum is involved is the loss of voice modulation. There's people develop an explosive speech, and you may think that they're yelling at you and they're angry, but they don't recognize that they are yelling. It goes soft and then suddenly loud and a little soft. They lose that modulation of voice that comes with cerebellar diseases. It's called explosive speech. In terms of extremity testing, we look for things like intention tremor, titubation, which is a central tremor or an axial tremor of the body, particularly if the vermis is involved. We talked about dysmetria with regard to eyes. With regard to extremities, dysmetria is pointing past the finger and not reaching its target, falling short of it. Finger to nose and heel to shin ataxia is again very common. I have some examples of this in a video, I think. Dysdiadochokinesia is imprecise execution of rapid alternating movements done in a specific way. Impairment of check is again one kind of dysmetria in which you have the patient follow your finger, but they overshoot the target. And then dysenergia, not a commonly recognized sign and often confused with functional disorders, is there's a breakdown in movement. You ask the person to touch your finger and they are not able to, they're very slow. You may confuse it with bradykinesia and, oh, are you just not interested in performing the exam? What's going on here? But you have to put it in clinical context. It is important to remember not all of these symptoms and signs are present in everyone. So we have to do a thorough clinical examination to elicit these signs, and they may be present in different people at different times as the disease progresses. So that's again a little complex, but it's good to have these in your mind as you're performing the exam. The most telltale sign is wide-based gait, unable to perform tandem gait or walk one foot in front of the other. I gotta tell you this is very important, folks. This sign in isolation alone is not equal to cerebellar disease. We see that in many, many conditions. We see that in neuromuscular conditions. We see that in people with toxicity. We see that in many conditions, but that is not by itself a sign of cerebellar dysfunction. You ought to have some of these other signs present to say, yes, the cerebellum is involved. It's not just a problem with walking. And then I alluded to this, the cerebellar cognitive affective syndrome, also called the Schmamann syndrome. This is important to recognize because it's not easily identified as the cognitive, the emotional, and the behavior issues that occur with cerebellar disease. This was presented in a seminal paper by Jeremy Schmamann at MGH. So it's also called the Schmamann syndrome. It's a complex of various things that the patient is not able to do, set shifting, visuospatial problems, executive problems, but also inability to complete thought. Thought jumping from one thought to the other, thought dysmetria, and a complex constellation of these neurobehavioral, neuropsychiatric symptoms is called the cerebellar cognitive affective syndrome. How do you elicit this? Difficult, but there is a scale. In our clinic, there is a scale for everything, and if you have time to perform it, that is. All right, what about the etiological classification of ataxias? Again, complex. Having a framework of this classification in your mind helps you diagnose or generate a differential diagnosis really well. Very simplistically, cerebellar ataxias are divided, like most other diseases, into acquired causes and neurodegenerative causes. The neurodegenerative ataxias are what we see most commonly in the movement disorders clinic, and they are classified further into the genetic category and the sporadic. The sporadic are further classified into the neurodegenerative diseases that we see commonly: multiple system atrophy cerebellar, progressive supranuclear palsy cerebellar. I'm just going to mention this disease once because in the movement disorders clinic, it is a mimicker of cerebellar ataxia, but it's a rare condition and it's not very commonly seen in the community, but we just have our antenna up for this particular condition because it can look really like cerebellar ataxia in the initial stages. And then we have that wastebasket category that exists in every specialty of medicine, the idiopathic. Doctor doesn't know what you have. You have something, but I don't know what you got. In terms of ataxias, we have to wait and watch what happens to these idiopathic ataxias. And here's a really busy slide, but I've circled the genetic ataxia category. The sporadic category, as I said, is primarily MSAC, cerebellar, and ILOCA, which is a fancy acronym for idiopathic late onset cerebellar ataxia. It is really not a diagnosis, it's a description. What happens over time is about 30% of people with ILOCA develop signs of multiple system atrophy. So you have to follow them, and we'll see what MSAC is in a bit. And then the rest are diagnosed with a genetic condition depending on progress in the area. As new mutations are discovered, people who were told that they have idiopathic undiagnosed ataxia can be retested, and lo and behold, at least a third of them have genetic mutations. How often to test them? We don't know. We don't have any protocols. As often as you're able to, as often as they can afford, and as often as the literature puts out that there is a new mutation. So that is dependent on the provider and the patient. I have a lot of acronyms over here. I had a ton of them. I removed them. But the two ataxias that I allude to, the two categories are the mitochondrial and the X-linked. The mitochondrial ataxias are ataxias due to mutations in the mitochondrial genome itself. A majority of the mutations that cause mitochondrial dysfunction occur in the nuclear genome, not in the mitochondrial genome. But the mitochondrial genome has about 150 kilodaltons of nucleotides and can demonstrate mutations, have mutations. One disease which mimics ataxia is the mitochondrial encephalopathy with lactic acidosis and strokes. Rarely it can present purely as ataxia without having any strokes. And then we have the other condition called FXTAS, which is an X-linked condition under the X-linked category, fragile X tremor ataxia syndrome. I'm just going to mention these before we move on to autosomal dominant and autosomal recessive ataxias, which are the largest category of ataxias we see in our clinic. ALD-ALN is an acronym that stands for adrenoleukodystrophy and adrenoleukoneuropathy. Again, in X-linked diseases. The peculiar thing about X-linked diseases is although they are much more common in men, women to some degree can be affected by these conditions. They don't have the full-blown phenotype. So unfortunately, if you have an X-linked condition and you're a woman, you may not be completely spared. Anyway, so moving on, the ADCA, ARCA, autosomal dominant cerebellar ataxia, the autosomal recessive cerebellar ataxia is the largest category of ataxias we see in our clinic. Of the autosomal dominant cerebellar ataxias, the spinocerebellar ataxias predominate. Of the spinocerebellar ataxias, those ataxias that occur due to a repeat expansion of the nucleotides predominate, and of those that are affected by triplet repeat expansions predominate in the world. And those include SCAs 1, 2, 3, 7, 8, 12, 17. It's a numerical soup, but we who do a lot of this have this memorized, sort of, the triplet repeat ataxias. The episodic ataxias, EA, and the dentatorubral delusion atrophy, not very common. I've seen a couple cases of DRPLA and maybe one case of EA or EA2 in the past 20 years. EA is very often a disease of children and adolescents. Autosomal recessive ataxias, every day the number is growing because we are now in the era of next generation sequencing. Whole genome sequencing. So the more we sequence genes, the more we recognize genes. As you know, most recently, the entire Y chromosome was assayed after 25 or 30 years, and they found mutations of the Y chromosome that could be related to cerebellar ataxia. But the alphabet soup here is FA, Friedreich's ataxia. Canvas is the newest kid on the block. This used to be classified as a syndrome and idiopathic ataxia until 2 to 3 years ago. And we found out that all these people who have cerebellar ataxia, neuropathy, vestibular areflexia syndrome, we used to call them, have a mutation in this gene, RFC1. It's a pentanucleotide expansion in the intronic portion of this gene. And a third or maybe half of them present with this particular syndrome. AT stands for ataxia telangiectasia. AVID, ataxia with vitamin E deficiency. AOA 1 and 2 is ataxia with oculomotor apraxia 1 and 2. RSAX is again a mouthful. I'm sure it has a better acronym, but it stands for autosomal recessive ataxia of Charlevoix-Saguenay. It is particularly common in French Acadians, and particularly in Quebec. POLG ataxias are due to nuclear genetic mutations affecting mitochondrial function of the DNA polymerase gamma enzyme, which is responsible for DNA repair. CTX, again, a rare ataxia, but we've seen a couple cases, and treatable, cerebrotendinous xanthomatosis, and lots, again, rare, but you have to keep your eyes open for late onset Tay-Sachs syndrome, common in Ashkenazi Jewish population, as a lot of autosomal recessive ataxias is. And it can cause pure ataxia, but it causes other things like hepatosplenomegaly, et cetera, so you have to look for it. Moving on, this is again a throwback to our medical student resident days. This mnemonic, where mnemonics used to rule, everything was a mnemonic because you had to remember things. A vitamin is what I use. We're not going to go through it because it's fairly evident. Again, you have to be very careful using mnemonics to order diagnostic testing. You can't shotgun everything for everyone who has cerebellar ataxia. But when I'm meditating about what this person has, pre-charting, thinking, okay, I've done these 3 tests, what else needs to be done for ataxia? I often go back to the basics to figure out what's left and what is prudent, cost-effective to order. It is important to recognize that other than the actual ataxic syndrome or ataxia, ataxias are multisystemic disorders, primarily the neurogenetic ataxias, because the genetic mutations are ubiquitous. They affect other parts of the body, not just the cerebellum, and other parts of the brain. So in addition to the ataxic component that we talked about, we are always on the lookout for tremors, dystonia, spasticity, and cramps, Parkinsonism, chorea, myoclonus, oscillopsia, nystagmus, all of this. Why? Because all of these are particularly amenable to pharmacological treatment. So what I'm doing is trying to make a point of the fact that cerebellar ataxias are treatable. They may not be curable, but they are treatable. And why am I making this point? Because back in the day, when I did my residency in medical school, etc., we were told by a lot of the attendings, ataxia, genetic, it's motor, just let it go. It's, you don't have the gene. Why do you want a gene test? They're not treatable anyway. Just send them to rehab. These are things that we have heard, and there is a nihilism associated with cerebellar ataxia that we really want to disabuse at this point. Ataxias are immensely treatable, just like other neurological disorders, and you break it down into its various components. Oftentimes people will come and tell me, I have ataxia, I understand, but what are you going to do about this tremor I have? And I've got this horrible dystonia of my foot, which is hurting me. Can you help me with that? Sure, we can. So ataxias are treatable. You just have to talk to the patient. Some are curable. That is important to recognize too. And then you have all of this. You got the neuropathy, the myotrophy, autonomic dysfunction, visual loss, sensory neurohearing loss, sleep disorders, neuropsychiatric issues, pain, vertigo, seizures. Again, this slide is to illustrate the point that multidisciplinary treatment is needed for cerebellar ataxias. And we don't have to go into each of these. And I call on my colleagues here, my neurology colleagues, to help me. I've called in my epilepsy colleagues when I've had a patient with SCA10 and cerebellar ataxia and epilepsy. I'm like, please help me manage this, because that is an integral part of that particular ataxia. And then we have multi-organ dysfunction, so I have to call on subspecialists from other areas too. My cardiopulmonary colleagues, orthopedic colleagues, endocrinological, ophthalmological, dermatological colleagues. Cancers are common in certain ataxias. And then when visceral organs are involved, I have to call on that particular subspecialist. And so we look at ataxias as a multisystemic disease, although the primary culprit, which presents the signs that people come into in the neurologic clinic, is the cerebellum. What about clinical progression? Does that give a clue as to which etiologies are involved? I think it does. In the acute setting, which Dr. Doherty and a lot of the neurohospitalists, et cetera, see, we look at vascular, structural, viral drugs, multiple sclerosis, lesion, and antibody-mediated ataxias, because this can progress in minutes to weeks, even quicker. Subacute ataxias are mainly acquired as well, but subacute is the gray area which straddles acute and chronic. Vascular, structural, substrate deficiencies. What do I mean by that? Vitamin E deficiency, vitamin 12, etc. Uncommon, but important to test because potentially treatable. Viral and antibody mediated as well. Now, as you know, each of these could be a talk, so I'm going to go really quickly through these. The chronic ataxias are the ones that are typically due to genetic mutations and multiple system atrophy. So we are always on the lookout for these genetic conditions and sporadic conditions. Rarely gluten ataxia and some substrate deficiencies that have been undiagnosed for years can present this way, but not often. And then the episodic ataxia, as we already talked about, they're episodic by nature of the pathomechanism. Episodic ataxias, the EAs are usually channelopathies, and those neurological diseases present paroxysmally, sporadically, mitochondrial as well, because they're dependent on the internal energetics of the body, which can vary. How about diagnosis in a singleton 70-year-old person comes in the clinic with ataxia, no family history whatsoever, no risk factors? There are 2 or 3 tiers, at least. Let's get neuroimaging. Let's look at the brain if it's not been done. Is it cerebellar ataxia? Is the cerebellum affected? Very basic stuff. Then we talked about basic serologies. I always include a 12-lead EKG because based on my experience, some late onset ataxia, genetic ataxias can affect the heart. cardiomyopathy, conduction blocks, et cetera, and they may not be diagnosed for a long time unless you look for it, particularly in people who haven't been to their primary doctors in years. And we have those folks as well. A second tier evaluation includes the more expensive evaluation for relatively rarer diseases, CSF studies, CT of the body and PET to look for neoplasms, paraneoplastic diseases, specialized serum screens such as alpha-feta protein, cholesterol. These screens are important because they can actually give you a clue as to whether there is a genetic ataxia at hand. And even before doing genetic testing, you can actually look for some of these clues. And then EMG, if I suspect that there is a predominant neuropathy or neuronopathy, I ask my neuromuscular colleagues to help me because that clues me into the kind of ataxia. Vestibular tests have become common now because of Canvas. You can do a head impulse test in the clinic, but I'm not very good at it. Plus, I'm also a little concerned about tweaking people's necks and shifting them right and left quickly. We have older patients and you don't want to cause damage. So I haven't learned to do a good HIT, so I order vestibular tests to look for vestibular areflexia. And that's part of that Canvas testing. And of course, genetic testing. Skin and muscle biopsies has fallen by the wayside. We really don't do them anymore, except for some very rare conditions, and the genetic test shows, variants of unknown significance, which is the bane of our existence in genetic testing, because we don't know what to do with that. Then we have to do higher level tests. So that's half the talk. I think I have some time to present the cases. The case one is a 55-year-old woman with slowly progressive walking and balance problems in her early 50s, leading to sporadic falls. She saw us 1 to 2 years after symptom onset. She had mild urinary frequency and urgency, nothing out of the ordinary, no family history of similar symptoms. The rest of her history and review systems were normal. She didn't have any risk factors for communicable or opportunistic infections, travel-related infections, etc. So, on initial examination, her cranial nerve exam was normal. She had very subtle speech dysarthria, normal strength, tone, bulk, and sensation. Her reflexes were brisk but symmetric. 3/4 toes were plantar. She had a spastic, slightly wide-based gait and impaired tandem gait, which is not surprising given her complaints. She had no Parkinsonian signs whatsoever. So here is a 55-year-old woman, and in the differential diagnosis of gradually progressive chronic ataxia, possible bladder involvement, maybe not, what comes to mind? I can make this as interactive as possible, but in the interest of time, I'll proceed. Does someone want to shout out something? Okay, yeah, great. We think about SCAs, spinocerebellar ataxia is exactly right, but we also think about other things, basically 2 to 3 years. Could she have one of those vitamin conditions? And I really mean vitamin B12, vitamin E deficiency. Connective tissue diseases such as Sjogren's disease can present strangely with this kind of progressive ataxia, with only ataxia. Gluten ataxia can present exactly like this over 2 to 3 years. And then immune-mediated ataxias we keep in mind because I've diagnosed people with anti-GAD65 antibody-related ataxias 10 years after the onset. And so it just depends on how much workup the person has had previously and at what stage they come in. Usually people don't come in on the first day they start experiencing neurological symptoms unless it's an acute case. And genetic conditions, as Dr. Elliott said, SCAs. Which SCAs? The most common ones, the triplet repeat disorders. She doesn't have a known family history. Does that exclude autosomal dominant diseases? No. The history may be incomplete. Patients may not be aware of it. They may be adopted. And there could be de novo mutations. Okay, and then in terms of the autosomal recessive cerebellar ataxias, we have the most common ones, which are Friedreich's ataxia, RSACs, the lots, which is not as common in POL-G that we look at. Of all of those, Friedreich's ataxia is one of the most common that can present late in life. X-linked ALD-FXTS, not very common in women. Let me keep it in mind. Sporadic ataxias must be kept in mind in this age group. Chronically, gradually progressive ataxia, some bladder problems. Does she have the beginnings of multiple system atrophy cerebellar, or is this just an iLoca? We have no answer. It's 3 years or 2 years. But as I told you about iLoca, you wait and watch, right? So we did the basic first-year evaluation, MRI brain, spinal cord, and then progressively serum CSF studies. Even genetic testing was completely normal. So we eliminated the SCAs and the autosomal recessive ataxias. It was done sequentially in a cost-effective way so that she could afford it. Back in the day, this case is about 5 or 6 years ago, we did not have ready access to whole genome sequencing. So is this an idiopathic late onset cerebellar ataxia, and should we just leave it there? I follow patients every 6 months to see what happens. So we didn't leave it there because this is what happened over the next 3 years. She developed dysphagia and dysarthria, no stridor, which is difficulty breathing due to abnormal contraction of vocal cords, sporadic dream enacting behavior, which is REM behavior disorder. She developed more urinary frequency, urgency, and incontinence, significant orthostatic hypotension, and mild Parkinsonism and rigidity. Cognition was relatively intact. So I think at this point, I've painted the picture of a particular disorder, which is, yes, exactly right, multiple system atrophy C. So she satisfies the clinical criteria for MSAC, or does she? Well, as in neurodegenerative disorders, we have made things more complex. Why? We don't have biomarkers. But clinically, she had clinically probable MSAC. This was prior to the most recent guidelines for MSAC, which has levels of certainty, clinically probable, clinically established, et cetera. At that time, she had clinically probable MSAC. DAT scan was normal, which is surprising, right? A dopamine transporter scan should be able to identify atypical Parkinsonian conditions. But in MSAC, 50% of DAT scans can be normal initially. So that did not sway us from the clinical diagnosis. I don't know how we did it, but we got a brain FDG PET approved, without her paying an arm and leg for it. You cannot do it now. But it actually showed telltale hypometabolism in the putamen and the cerebellum, which is now considered a abnormal MRI marker, a supportive diagnosis for clinically established multiple system atrophy. So what is multiple system atrophy? It's one of 4 alpha-synucleinopathies, which is a neuropathological term. It's not a clinical term. The others are listed here: Parkinson's disease, Lewy body dementia, and pure autonomic failure. Pure autonomic failure is not very common. We see it rarely. What do you see in the brains of people with multiple system atrophy? Because the definitive diagnosis is brain pathology. That is the gold standard. We see these arrows pointing to something very specific, these eosinophilic inclusions called glial cytoplasmic inclusions. So interestingly, the primary inclusion that is seen in the brains of people with MSA is not in the neurons. It's in the oligodendroglia, the supportive cells. It is still a mystery how they get involved. There are lots of hypotheses, but this is really interesting. There is neurodegeneration, of course, of bilateral putamina, brainstem nuclei, etc. But this is sort of the gold standard neuropathological sign of multiple system atrophy. All right. So what are those irritating diagnostic criteria that we have to look at, or et cetera? It's almost like a legal document, but it's a progressive ataxia or Parkinsonism, which is not responsive to levodopa. That's left to the examiner. Dysautonomia has to be present. No dysautonomia, no MSA. This is very important to recognize. And that can take the form of urinary dysfunction or neurogenic orthostatic hypotension. And the urinary dysfunction can take the form of frequency, urgency, incontinence, or a post-void residual, which is high, greater than 100. That is difficulty to urinate because of neurogenic bladder. And neurogenic orthostatic hypotension is defined as a drop in blood pressure of at least 20 to 30 millimeters of mercury from a laying down to standing position systolic, or 10 millimeter mercury diastolic, without a compensatory increase in heart rate, hence neurogenic. There is denervation of the nerves that affect the heart. And so that needs to be demonstrated. MRI brain markers, which we will see in a bit. And then there's a whole bunch of exclusion criteria. Now, this is the weird thing about neurodegenerative diseases. These exclusion criteria are the inclusion criteria for other diseases. And their exclusion criteria includes MSA. So you can see that the logic is kind of complex. So here, we don't necessarily satisfy every exclusion criteria, but there are some red flags like frank dementia. People with multiple system atrophy do not get frank dementia unless there is another process. And I wanted to tell you that the previous pathological slide, which showed glial cytoplasmic inclusions, did not show Lewy bodies, but it is classified as a Lewy body disease because the protein in those inclusions is alpha-synuclein, which is the fundamental protein in Lewy bodies in the brain. Then you have a whole bunch of other things that are going on in MSA that we look for. There are supportive markers and supportive signs: REM behavior disorder, dystonia, pyramidal signs, extensor toes, hyperreflexia, and then the whole autonomic issue, which can manifest as very troubling gastroparesis, early satiety, postprandial hypotension, where they can faint after eating a large meal, nocturnal stridor, dysphagia, and respiratory failure. The average longevity is 3 to 9 years. So this condition mimics what Dr. Elliott treats in his clinic, ALS. We call it the ALS of movement disorders, although of course it's very distinct because of how rapidly it progresses. We don't have a cure for it at this time. So we talked about MRI markers. Everyone talks about this hot cross bun sign. I'm sorry that FDG PET is covering that, but maybe I can minimize it and see where it is here. Okay, we'll just let it go. Maybe it'll show up later. There's transverse pontine dysmyelination, and that classic sign is known to be seen in MSA. It is classic, but not common, just like everything in neurology. We talk about the classic, but it is not common. And interestingly, it's not specific for MSA either. So we can't look at a hot cross bun sign in the MRI and say, you got MSA. The diagnosis is still clinical. The yellow arrows are pointing to putamenal hypointensities, that is striatal necrosis that is seen on FLAIR and T1 imaging. And then this big white arrow here is pointing to pontine atrophy. This could be one of the most specific signs for MSA. There are papers being written about pontine atrophy at the rate of 1 millimeter per year, more specific for MSA than for other neurodegenerative conditions. And as the brainstem is shrinking, then we see things like a fourth ventricular enlargement and then cerebellar atrophy, which is of course a separate process that can be seen primarily in MSA-C. This is the FDG PET scan of someone with MSA. Hard to get in the US, but just for illustrative purposes, what you see in the colored areas are areas of hypometabolism in the cerebellum, bilateral putamina, and other parts of the brain, specific to about 80 to 90% in multiple system atrophy. It distinguishes it from other diseases in which the metabolic patterns are different. These are the signs of MSA that we treat in our clinic. So it is a treatable condition. We won't go through all of this, but suffice it to say this mandates multi-systemic, multidisciplinary treatment. So we have a team that we have to assemble, and we have that right here at Swedish. We have the neurologist, the PCP, the neurorehabilitation specialist, the otolaryngologist, the pulmonologist, the sleep specialist, urologist. We have a fantastic social worker in our clinic now, Providence Home Health Services, mental health counselors, neuropalliative care. The mental health counseling has to be farmed out. We don't have that component yet. All right, we'll move on because we have only 15 minutes. The second case is a 77-year-old woman who was first evaluated at age 73 with progressive difficulty in gait and balance since mid-60s. So this is a very chronic condition. She's had numerous falls. She transitioned to a walker recently. She had slurred speech, occasional dysphagia, increased urinary frequency and urgency. At one point, she was told that she had GAD65 antibody syndrome. Because the antibodies were supposedly elevated in her blood. And she told that, oh, you're unstable because you've had a retinal infarct, because she had a factor V Leiden deficiencies. Unaware that other family members have this problem. There's parents not related, no consanguinity, no tobacco, and very rare alcohol use. On exam, extraocular muscles were interestingly normal. Speech was slightly slurred to normal strength and tones. Reflexes were 2 throughout, but toes were upgoing. I would say reflexes were 3 in retrospect when I saw her recently. Pinprick and vibratory sense was decreased in feet. She had classic bilateral finger-to-nose dysmetria, heel-to-shin ataxia, and dysdiadochokinesia, all signs of cerebellar dysfunction, a very wide-based gait. She had to use a walker. SARA is a scale that we use for grading cerebellar ataxia. We don't have to go into this, but a score of 14 over 40 is fairly disabling. Basically grades various body parts. So I'm hoping this video will play. And you can watch it. I don't have to say anything. That's a very good bilateral Babinski on both sides. It's reproducible. And that's her gait, wobbly, ataxic, using a walker. I didn't want to make her walk tandem, of course, because of the high risk for falls. Right, so that is some demonstration of the cerebellar exam over there. Retained reflexes, extends her toes. So what is the differential diagnosis for a progressive adult onset spastic ataxia that she's had since the 60s, which she was told is due to GAD65 antibody syndrome? It could be GAD65 antibody syndrome, undiagnosed for many, many years. All right, anything else? Anybody shout it out? Nope. Okay, no takers. We'll move on. All right, acquired is highly unlikely, even though she was told she had GAD65 antibody, which were rechecked and they were just mildly abnormal. In my mind, I immediately jumped to the chronic ataxias, the genetic conditions. Highly unlikely for her to have multiple system atrophy after all these years with hardly any autonomic dysfunction. I thought of these spastic ataxia mimics, both autosomal recessive and autosomal dominant. SPG7 is an autosomal recessive ataxia mimic. In fact, all hereditary spastic paraparesis are mimics of a spastic ataxia, or can present as spastic ataxia. A de novo mutation in SCA, could it be RSAX? She was not from Quebec, but it can happen. And then very late onset Friedreich's ataxia and some of the other conditions I listed over here, which are much rarer and less likely. And what we did was that basic diagnostic investigation, first to see if the cerebellum had shrunk even more and to what extent. We did MRIs of the brain and spinal cord, and the basic serum and CSF studies, because we wanted to ensure that she did not have GAD65 antibody syndrome. And one way to eliminate that is to do CSF studies and show that the antibody is absent in the CSF, which was the case in her. Her MRI showed that the cerebellum had not shrunk much between 2011 and 2019, but she was clearly ataxic, right? That was interesting. In comparison, here's someone with SCA6, a pure cerebellar ataxia that can present like this, and look at their cerebellum, very shrunk. So it gives you a clue as to what ataxia can progress with preservation of the cerebellum, but look at her spinal cord. It is fairly atrophic. We don't have measures. We've tried to get them. We can never, because we don't have normative values that can be applied. But that is an atrophic spinal cord. To preserve cerebellum, atrophic spinal cord, it narrows it down a little bit. So with that in mind, we decided to go for genetic testing, both with pre and post genetic counseling. A lot of the tests were normal, but whole genome sequencing was done, and she had a very late onset presentation of Friedreich's ataxia. Now that is not common, because Friedreich's ataxia is a childhood onset condition. but she had very expanded allele, homozygous, bilateral. And so that was a find after 10 or 12 years of not having a diagnosis. At the fourth appointment, she tells us maybe her sister has similar symptoms. So this came to our attention much later. So I said, okay, well, that's very interesting. Let's look at your sister. And that's her sister. And we called her into the clinic to do a test. And clearly she was very ataxic. And she also had fairly brisk and retained reflexes. So I'm like, that is a coincidence. If this is an autosomal recessive ataxias, she had another sibling who was not affected. And so her sister is able to walk relatively independently, but is still very ataxic. So we decided to test the sister for exactly that same gene. And her sister had bilateral homozygous pathological GA repeats, also confirming Friedreich's ataxia, very late onset. Classic Friedreich ataxia presents in adolescence, and people are wheelchair bound by their 20s. Atypical Friedreich's ataxia presents as a spastic ataxia, myelopathic signs, no cardiomyopathy, endocrinological or prominent orthopedic issues, and people can be ambulatory. So we keep this in mind when we are evaluating late onset ataxias, and more of these cases are being reported. This is the only ataxia for which we have an FDA approved treatment. And this was released only 3 months ago. It's omaveloxolone, which is an NRF2 upregulator. NRF2 is a transcriptional factor for the frataxin gene. The frataxin gene is mutated in Friedreich's ataxia. The frataxin gene is responsible for mopping up the redox species in mitochondria, the ones that cause damage. So NRF2 increases the production of frataxin and thereby reduces the redox damage, reactive oxygen species, and mitigates the ataxia and improves function according to the study that was done recently. I've prescribed it recently. We're waiting to see what happens, but we have to monitor transaminases, cholesterol, and BNP, etc. So Friedreich's ataxia also requires multidisciplinary treatment. We are in the last stretch. I'm not going to stress that all of these folks are involved in the treatment of Friedreich's ataxia. There are lots of non-FDA medication supplements and devices that we won't go through, but this is just a list of non-FDA approved things that we use in our clinic for some of the ataxias. I don't use valproic acid. I don't know how that got in there, but a small study showed that it improved function in SCA3 individuals. There's a lot of research going on. There's about 42 interventional studies in ataxia, and then there are cell-based and genetic studies in the preclinical stages. We have assembled a multidisciplinary team with all of these building blocks. And in the movement disorders clinic, we are waiting to grow our neuropsychiatric and mental health component, which is lacking, which is important. The neurogenetics component has been farmed out. At some point, we hope that we will be able to get that in-house as well. Most importantly, keep the patient and family in mind. Even in multidisciplinary care, people may not want or need everything. This is our We Movement Disorders team. We work hard, but we also have fun. Some of them are here. Thank you for coming. And then we have the other blocks, the neurorehabilitation, neuropalliative, led by Dr. Lee, our neurology subspecialists who are here, neurosurgeons if we need them, neurocognitive specialists, neuroresearch, which is growing, and neurogenetics, as I said, we have contracted with a company, but we hope to hire our own in the future if possible. And as Dr. Elliott said, we have attained the certification of Center of Excellence. We're very proud. In summary, ataxias are treatable. Diagnose them promptly. Comprehensive ataxia treatment is warranted because they're multisystemic disorders. And then if you want to learn more, come to the Ataxia Clinical Training Program, which we founded with National Ataxia Foundation. The meeting in Orlando next year, and you can apply and register for it. It's going to be a fun meeting. And with that, I conclude with 4 minutes for questions. Thank you. Questions?
Yeah, Pravin, if you have someone with a toxic cerebellum, a cerebellar appearing exam, do you think it's the toxin betraying some underlying cerebellar risk, or is there some thread about the toxins that you're aware of that might make cerebellar dysfunction more likely?
You're talking about, like, say, alcohol as a toxin, or?
Yeah, or lithium, or I've seen dilantin, for instance,
Yes.
cause Vermian atrophy. Does it mean that there's an underlying genetic or other issue that the toxin helped exacerbate? And do you ever spend any time working it up beyond
Yes.
just removing the toxin?
We absolutely do. Because I don't see as much toxin-related ataxia, one of the things I look for is progression after the toxin has been eliminated as a clue. But if you're asking, is there a genetic propensity that renders the cerebellar cells vulnerable to that particular toxin in one patient versus another, that is not well known. I feel the truth is somewhere in the middle. But I look, and thus far I've diagnosed 2 people, one with SCA5 and the other with SCA12, who were told that they had alcoholic cerebellar ataxia, but the ataxia continued to progress. Interestingly, they were very heavy alcoholics, 1 or 2 bottles of wine a day alcoholism. So that answers your question in a roundabout way, that there is a vulnerability, but the gun is loaded, I think, and the toxin just fires it. I can't say that for everybody. Yeah. Any other questions? Yes.
I saw that spinal fluid was on your first tier out of diagnostics.
Second.
Second tier.
Yeah.
What are you looking for in basic profile?
Interestingly, I ordered the MS panel, which is a non-specific evidence of CNS inflammation, immunological disorder, oligoclonal bands, the cells, the protein, etc. Most importantly, lymphocytic pleocytosis, elevation of protein, presence of oligoclonal bands, which is common in conditions I see such as anti-GAD65M antibody ataxia. And then if I'm looking for a specific antibody, I request that as well. Does that help answer? Nothing specific. It's fairly non-specific. Yeah.
Dr. Khemani, there's a chat box comment and question from Karen Sanders. She said, great talk. Could you please speak to your protocol pre and post neurophysiological testing for treatable and other cases?
Neurophysiological or neurogenetic? Maybe it's neurogenetic.
She wrote neurophysiological testing for treatable in other cases. But
Okay, I'm going to interpret as neurogenetic because that's where we do our pre and post test counseling. That is derived from the Huntington Disease Society of America's guidelines. It is very important to do pre-genetic pre-test counseling to get long-term care insurance. This is, once you diagnose someone with ataxia or a genetic ataxia, they're not able to get LTC insurance. So this is particularly important for asymptomatic individuals. And then to help understand the test and the final answer, whether it be positive or negative, we have the same genetic counselor talk to the patient after the test has been resulted. If it's positive, they talk about reproductive counseling, they talk about risk to other family members, etc. We do have a company called DNA Visit that we have contracted with that does that for a specific charge, and they also try to find the laboratory that charges the least amount of money for the testing or is most cost effective. So that's our basic protocol.
Pravin?
okay, and she just said, please let the doctor know I wrote neurophysiological testing.
Okay. We don't have a specific protocol for neurophysiological testing at this point. Yeah.
Pravin, in really elderly patients, say 85, 90-year-olds, a lot of those symptoms sort of overlap with orthostatic intolerance, bladder issues, gait dysfunction. How do you spend your resources wisely there in that population in terms of working it up? Do you have any comments on that?
It's different for different individuals. If there's a singleton, no family members at risk. I tell them genetic testing is likely not going to change outcome at this point. At least let's look for some simple treatable conditions. So that's the very first thing we do. If they say, I would really like to pay for genetic testing, and I'm willing to do this, and I'm willing to spend $10,000 for whole genome sequencing, will you let me, I want to do it for my family members. Then I said, well, you have to get genetic counseling first, because as people age, VUSs go up. I have detected VUSs for breast cancer, for this cancer, for that cancer in whole genome sequencing. And someone has to take responsibility for telling the patient that. So genetic counseling is critical for genetic testing, but I don't use up a lot of resources for acquired causes unless I actually see that the ataxia is rapidly progressing. One category of treatable ataxias is the immune-mediated. So I have diagnosed 85 years old with steroid-responsive ataxia or G8065 antibody ataxia, and we have treated them and their course has stabilized. So we look at the overall condition, but if it is, we have to, you're right, it's complex to separate from age-related, and it is dependent on the conversation I have between the patient and myself. But we don't shotgun diagnostic investigation for everybody.
Thank you.
Dr. Khemani, my apologies. Karen said neuropsychological testing. Do you have an answer for her with that?
When do we refer? We do simple tests in the clinic, screening tests. We have our excellent team doing MOCA and RUDAS in people who don't speak English. English is not a primary language. Depending on that, we determine if someone needs neuropsychological testing. If estate planning is an issue, if family members are at war, if they say, no, we want, this person is not of capacity and we want to take on the family resources, et cetera, there are legal issues also. So we look at the patient and then we determine if neuropsychological testing is needed. But first we do screening tests in the clinic. Yeah.
Corey, can you let people know what the code is for CME? In the audience here, though? Okay, perfect.
All right, well, thank you guys, appreciate it. Back to the salt mills. Yeah, thank you very much.
Thank you so much. Great talk.
Thank you.
Pumping it up. Picking up steam. Where was this bacon and fruit or something?
Well, it's like